Hello, welcome at EHJ Today, and we are here in Davos at Cardiology Update 2017, and now we are going to discuss the guideline, ESC Guideline on infective endocarditis. I'm Alec Vahanian from Paris, and it's my pleasure to introduce our speaker, Gilbert Habib from Marseille. So Gilbert, welcome. And you are going to tell us, to teach us about these guidelines, which were written in 2015, if I'm correct. Huh? But you also wrote guidelines on infective endocarditis in 2009. So why are you writing and rewriting guidelines? What happened between 2009 and 2015, which could be important for our practice?
Thanks, Alec, for your question. I would say that the 2009 guidelines were already innovative for several points, but there are really several new things in the new guidelines 2015, and I would say that probably the two main things are the new concept of the endocarditis team first, and the second, new use of imaging techniques in the field of the carditis. I think there are really new things, and we have some reasons to update these guidelines for these two main innovative ideas. Okay, so you make the point very correctly. So the heart team, it's very popular, transplant, TAVI, now the new percutaneous mitral repair, coronary angioplasty and bypass. So what are the specifics of a good infective endocarditis heart team? Yes, we followed the idea of the heart team, of course, but we really wanted to have a separate name, not the heart team for endocarditis, but really the endocarditis team, because it is really now what several centers and ourselves are doing in our clinical practice. That is, putting the patient at the center and to have around the table several specialists, cardiologists, of course, cardiac surgeon, of course, infectiologist, of course, but also sometimes other specialists. And the idea of the heart team is, and the carditis team in fact, is that the disease is so severe with a so deadly prognosis that we need to have the best person at the best moment to treat the patient. And we can have around the table, depending on the clinical presentation, radiologists, specialists of nuclear medicine, neurosurgeons, neuroradiologists, and so on. So really, to have a benefit for the patient, we need to be around the table. And the difference from the previous guidelines, and during that time, there are several papers published on this topic showing that it's not only to be around the table and to be friendly talking about cases, but it is also because this approach had really been shown by several centers as able to give a better prognosis for the patient. Okay, but Gilbert, can you tell us in practice, are you discussing all cases? Any cases, even the very simple one, or are you focusing on the complex cases with several locations? I think what we do in our clinical practice is to look at all the cases hospitalized at one moment in our department. Of course, we spend more time in more difficult cases, but what is important is that at the end of the meeting, we write something and everybody is as information of what has been decided during the meeting of the endocarditis team. So all the cases, but of course focusing on the most difficult. And at the end, the most important is also to take the best decision for the optimal timing for surgery. We understood it, that's the point. But do you network with other centers? Do you propose a sort of service for smaller hospitals, smaller groups? This is an important point, and it is also written in the guideline. There are two categories of centers. The reference centers, in which the patients are hospitalized, the most severe patient. What does it mean? That means patients with complicated endocarditis, that is heart failure, embolic event, or persistent infection. These patients should be in the reference centers, and the case should be discussed in the reference centers. But other centers, peripheral centers, for example, should not send all their patients, but they should have the possibility, and they have, to have phone discussion, sending images, pictures, or echo to the reference center, and then to discuss the case. And also sometimes they send the patient just for a consultation for 1 day, and then he go back to the secondary center. So yes.
So Gilbert, you nicely set the stage. You spoke about the global organization, but you pointed the importance of imaging and the new features. Can you tell us a little bit more about that?
Yes, I think one of the reasons for these new guidelines was also the changing approach of imaging in infective endocarditis. Of course, we know that echocardiography is the main technique, and many decisions come from the results of echocardiographic examination. However, we know that we have some cases in which echocardiography may be negative or may be lately positive. And in this situation, particularly in cases of prosthetic valve endocarditis, we know that other techniques, for example, PET-CT, may be useful to obtain an earlier diagnosis of infective endocarditis. But it's not only PET-CT. I would say that cardiac CT scan is also very useful. And now the concept which was introduced in these new guidelines is that, of course, imaging is very important, but not only echo, but we need to have the possibility to assess the case of the patient by echo, PET-CT, and cardiac CT if necessary. Not in all cases, but frequently.
So when we listen to you, Gilbert, it comes that if we want to build a center of excellence for the management of patients with valve disease, we need to have this group focused on endocarditis, and we need to have a quite sophisticated imaging facility. Do you think that the PET is something which should be in a valve center of excellence?
Yes, again, I think that...
It's a very political and difficult question.
Yes, but we have to keep in mind, probably PET is not the most important thing. The most important thing is to have everybody on the same place and able to treat the patient in an optimal way. PET-CT is one part of this objective, but it's probably not the most important. Keep in mind that, again, the mortality of infective endocarditis, the 1 year mortality, is about 20%. So it's more than the majority of cancers. So we need to give the best chance to the patient and to have reference centers.
Okay, so now to conclude, I'd like to have your opinion, and maybe you can say a word about Euroendo, because doing good things, improving your practice is very important per se, but the judge at the end is better patient's outcome. So you are also chairman of this ESC initiative, the Euroendo. Can you say a word?
Yes, with pleasure. We are very happy to have the privilege to chair this registry in Europe. It will be, I hope, a fantastic registry, because we hope to include at least 2,000 patients with infective endocarditis in Europe, and even a little bit outside Europe. The idea and the main objective is exactly this one: to know about the mortality of endocarditis in Europe, in the current status of the treatment and diagnosis of infective endocarditis. But it's not the only objective. And one of the objectives is to see how different imaging techniques are used in different centers in Europe, and also at the end, when and how the guidelines are implemented in these different countries. So yes, this is a very important objective for us and for the ESC.
That's the last step of the virtuous circle: knowledge, education, and registries. So Gilbert, thank you. Thanks to your team, your task force in the guidelines, and thanks for the ongoing effort on Euroendo, and thanks for EHJ Today for organizing this short interview.
Thank you for inviting.